This is Carol from the STS. This is the Adult Cardiac Surgery Database webinar for November 4th, and we will get started here. First, welcome and introductions. We have our IQVIA team and our STS team here with us today. From STS, we have Leanne Jones, Jane Hahn, Melinda Offer, and Sydney Clinton. Sydney is over our public reporting, and we'll just be going over that for the updates for 2021 in just a quick second. And then from IQVIA, we have Jeanette Hanna, Jean, Joe, Melanie, and Paul Meehan. So thanks everybody for joining, and thanks for all of you for calling in. Go through the STS updates and important dates. We're going to talk about capturing Medicare insurance. So please watch the whole presentation to see if we cover your question before answering or asking a question about that. Chronic lung disease coding update, aorta device update, and then the IQVIA update. We have a lot of information, so hopefully we can get through it all and still have time for a few questions at the end. These are the STS updates. Public reporting will be updated in the first quarter of 2021, and we will be using the data from Harvest 1 of 2020, which will include cases through December 31st of 2019. It will include all 5 of the ACSD composite measures, which will be the isolated CAB, isolated AVR CAB, isolated and mitral valve repair replacement, and mitral valve repair replacement with CABG. STS will send notifications to sites in the coming week with more information. You can contact Sydney Clinton with any questions at sclinton@sts.org. The consenting deadline for public reporting is December 1st. So if you choose to opt in for the to publicly report your Harvest 1 of 2020 data, be sure to do that by December 1st. Couple Harvest updates. We had to rerun, DCRI had to rerun the Harvest 1 results, which were updated this past weekend. So you may see some slight changes there in your in some of your results, but those were posted last weekend on the IQVIA platform. Harvest 3 is an analysis, and Harvest 4 is set to close on November 20th. We have heard from quite a few sites about either IT issues or staffing issues or a whole number of things going on and people asking for extensions. So we are discussing that internally, and we will have more information out to sites next week. AQO wrap up. All AQO sessions will be available for the entire year, all the way up until AQO of 2021. If you are going to claim credit, please do so by December 31st, 2020. After that date, you will not be able to claim credit. For those of you who did not attend AQO this year or did not purchase the online content prior to the meeting, it will be available for purchase in late November. We will not be offering CE credits for those who did not attend the live sessions. So we have, those are our updates from STS, and now I'm going to go into our dates. We have the monthly webinar today, and just a quick rundown of the things that we've talked about. User group call, possible extension for Harvest 4, which is currently set to close on November 20th. December 4th is your public reporting consent deadline. Webinars on December 2nd and December 16th. And then the last day to claim CEs for AQO is December 31st. Please note the day change for the user group call this week. It's moved to a Thursday, November 19th. I think that's a Thursday. Okay, and then we're going to go into, the date is going to be November 19th. And then we're going to go into the Capturing Medicare insurance. So we have quite a few questions about capturing Medicare and how to capture it with the different plans with Medicare Advantage and the Medigap or supplemental plans. So I just wanted to give a quick overview. I have a couple other slides to go with this. There's basically 5 different types of Medicare plans. We have the Plan A, Plan B, Plan C. Plan D is just the prescription drug coverage, so I'm not going to really count that as a hospital plan. And then we have Plan E and plans F, G, and N, which are kind of all lumped into the same. Plan A is for hospital insurance only. It covers inpatient hospital stays, skilled nursing home facilities, hospice, and some home health measures, some home health care. Plan B, which is what you would add on, people pay extra to have Plan B, is also called fee for service, And that would cover things like doctor's services, which if you have a physician seeing you in the hospital, it would cover those costs, or doctor's appointments, outpatient care, medical supplies, and preventive services like screenings and things like that. We get into Plan C, which is the Medicare Advantage plan, and it is a commercial alternative, which means it takes the place of Medicare plans A and B. When patients sign up to have a Medicare Advantage plan, they forego any of the benefits of having Plan A and B. They forego those plans because they switch that over to a commercial insurance provider for coverage. So that commercial insurance provider could be somebody like Blue Cross Blue Shield or Aetna or United Healthcare, and that is who is providing the payment, which for things that are typically covered under Plan A or Plan B of Medicare. So the patient forgoes Plan A and B. They have a commercial insurance providing coverage for them. Plan E and Plan F, G, and N. Plan E was discontinued to new enrollees in 2010. It is considered a Medigap or supplemental insurance, and it's like an add-on. So it works synergistically with your Medicare Plan A and B, and it covers extra things, or it covers in addition to what Plan A and Plan B cover. So you would have your Plan A and Plan B, Medicare would get billed first, and then whatever they didn't cover would get pushed on over to the supplemental insurance. And that typically, that is in addition to your traditional Medicare, which is traditional Medicare means Plan A or B. And that would include usually insurances like Blue Cross Blue Shield, Aetna, United Healthcare will be paying in addition. You would be paying in addition to what Plan A and Plan B cover. Now, Plan F, G, and N are also Medigap or supplemental insurances. The difference on these is they work alongside with Medicare Plan A and B. The reason why there's different plans here is it related to how the deductible is paid for your Plan B. So it's a same coverage, just related to what's the out-of-pocket cost for the patient. So it's, again, Medigap or supplemental insurance. These are in addition to traditional Medicare. So the patient would have Plan A, Plan B, and then they would sign up for a Medigap or supplemental insurance to cover any costs that Medicare didn't cover or pay in addition to what Medicare covered. So we're going to focus a little bit more specifically on Plan C and the supplemental plan. So again, Plan C, which is the Medicare Advantage, it's an alternative to Plan A or B. The patient forgoes Plan A or B. And to code this, if this is the primary insurance, that you would code commercially managed Medicare plan yes, and primary payer Medicare Part B no. This is the fee for service, that would be no. And I'll show you screenshots of the data collection form in just a second. The supplemental plans, Plan E's, F, G, and N's, these are supplemental and they pay in addition to Medicare. To code those, you're going to code commercially managed Medicare no, because it is not a commercially managed Medicare plan. The patient still has Medicare Part A and B, which is managed by Medicare. It's not managed by a commercial company. It's managed by Medicare. And you're going to code primary payer Medicare Part B as yes, as long as you see that they have that Part B insurance. They have that if they have Plan E, F, G, or N. So you were going to code primary payer Part B as yes. You're going to code a secondary as either commercial insurance or HMO, whichever is appropriate. So if the patient has a primary Medicare type A and B and they have a secondary supplemental, which is could be Blue Cross Blue Shield PPO, Blue Cross Blue Shield maybe HMO, or it could even be Medicaid. So if they did have Medicaid, you would code that in addition to primary Medicare. But if they had one of those commercial insurance or the HMOs, you would capture that in the secondary insurance section, whichever is appropriate. Now, there are some patients who are still working or in special situations who may have a commercial or HMO insurance as a primary, which is not a Medicare Advantage plan. So you have to be really careful when you look at those cards to make sure that the patient, you have to verify which one with the patient is primary, and the patient will know who gets billed first, and it should be listed on your face sheets. So you need to look and make sure that the commercial H insurance is not a Medicare Advantage plan and that it is actually primary. the primary insurance, which means it's the insurance that gets billed first. And then whatever they don't pay, then Medicare would pick up if that was the situation for that patient. It's much smaller numbers than patients who have Medicare primary with a commercial or HMO as secondary. So here's a couple cards and the data collection form, and thank you to Jerry for sending in these samples. I'm using them for my presentation. This patient has Medicare primary. These are two different patients. These patients have Medicare primary with a commercial supplement. So you'll see here, this is the Medicare card. The patient has medical A, which is the hospital. Part A and Part B, which is medical. And then they also have this Plan G, which is a Medicare supplement. It's from Mutual of Omaha Insurance Company, which is a commercial insurance company. I don't see on here anywhere that it says HMO. So I would code this as Medicare. Commercially managed Medicare plan, no. And the reason I'm coding this as no is because the primary is Part A or B. So the commercially managed Medicare plan is no, because this Medicare plan is managed by Medicare. It is not managed by a commercial company. So HIC number or MBI number, yes, and that would be this Medicare number here. And then primary payer, Medicare Part B, yes. So the first person who's going to receive a bill after this patient leaves the hospital is going to be Medicare. That's who's going to receive that bill. Medicare is going to pay their part. Whatever they don't cover, then will get billed over to Mutual of Omaha, and they will cover in addition to what Medicare. They'll supplement what Medicare paid. Same thing with this card down here, hospital Part A and B. This patient has an ART Medicare Supplement Plan F. It's from United Healthcare, which I know is a commercial insurance company, so it would be coded the exact same way. And then over in secondary, we're going to code, for both of these patients, we're going to code commercial health insurance as their secondary insurance. Oops. So that's how we're going to code Medicare primary with commercial supplement. Again, this is Medicare A and B is primary, commercial supplement is secondary. The next one is the Medicare Advantage Commercially Managed Medicare Plan. This is a sample of a card. The patient has, you can see down here, it says MA, which signifies this is a Medicare Advantage, and this is a PPO plan. So this is the only insurance the patient has. This patient has foregone or has decided that they are opting out of Medicare A and B. They're going with the Medicare Advantage plan. They're going to pay their money to Blue Cross Blue Shield for this insurance, and in return, Blue Cross and Blue Shield are going to provide what Medicare would cover under Plan A and Plan B, in addition to other services. So this is a Blue Cross Blue Shield Medicare Advantage PPO. It's listed here on the card. I'm going to code this as a Medicare plan, which it includes commercially managed. I know this is commercially managed because Blue Cross and Blue Shield is a commercial company. I'm going to code that as yes, which will not open up the HIC number. And then primary payer Medicare Part B is going to be no, because the primary payer in this, the first person to pay, will be Blue Cross Blue Shield. They'll be the only ones to pay. And then none in self will be selected as the secondary insurance. Okay, and then, so I see a question that says Medicare cards say Medicare A and B Part B only on their traditional Medicare card. What does this mean in the cases the patient doesn't have a commercial plan? So you would just code that as Medicare, and then as the fee for service or Medicare Part B as the primary payer. We're going to go into the chronic lung disease section. So we did have some updates come out of AQO. I'm not sure if this was one of them, but I think that it was. And it's related to using the DLCO or the DLCO-VA to determine lung disease. Because sometimes what we're seeing is that the patient has a normal FEV1, but their DLCO or DLCO-VA may show a higher severity level or more severe level. So we went to the surgeons, and we have had some expert pulmonary consultants provide us with information, and a decision has been made that we will allow sites to use DLCO or DLCO to determine chronic lung disease, the severity of chronic lung disease. And if you have all of these available, or you have an FEV1 and a DLCO available, you would code the worst severity of chronic lung disease according to whichever one has the worst severity. So if your FEV1 is providing you a range of mild, but your DLCO is showing you that it's moderate, you're going to code that patient is moderate. More information, this will start with November 1 cases, and more information is in the training manual, which will be posted the early part of next week. So please refer to the training manual for detailed information before submitting FAQs on this. Melinda, do you have anything to add?
No, I just want to second that. Please read what's in the training manual first before you start submitting questions, because there's a lot of good information in the training manual. We've worked pretty hard on this, so I'm hoping that this will assist you guys in coding lung disease easier.
Great, thank you. For aorta devices, we sent out an email late, I believe it went out on Friday. What had happened, first, I just want to apologize. We had an evolution of thought, and as we were getting information back on sites about devices that were not listed on the harvest sheet that we posted for the aorta devices under this model number field, devices that were being suggested were the difference on those devices is that it was related to the size of the device, that model number looking different than other sizes that were listed on that data collection on the model on the harvest code sheet. So in doing that, I started adding in the devices into the spreadsheet, and I came up, I'd like to show you what I came up with so you don't know that, or so you know that we're not doing this by the seat of our pants. Hold on one second, let me just move this over. So I'll just show you something here. So I took the devices from the aortic valve sheet, and thank you for everybody who sent in their devices that were not on this sheet, because that's what kind of led to this. And I'm glad that we noticed it now instead of a year from now, because it could have been messy. So all of these, the ones in yellow here on the left, are the devices that were on that sheet that were posted online. And as I went through adding in the specifics related to the size, so each size has a model number for each device. So if we look at 807, which is the Gore Viaban VBX balloon expandable, each size for that device has a separate model number. And sometimes these model numbers, you might be able to identify the sizes in them, but they are specific to sizes, but they're not always identifiable via the model number. So it's not always clear, like you don't see the size 08 anywhere in this model number. So I started making this list, and as I was getting here, I got down to about a couple hundred, almost 300 devices that would have been added in, and I only got up to, I don't know, 11 or 12 of the devices that were listed on the sheet, and I already had over 300 extra harvest codes that were going to need to be added in. So instead of doing that, I worked with Paul Meehan and Robert Habib in our research center to discuss the best way to have sites capture this data. We had a couple options, and it would have been to have all of the numbers in a drop-down list, which you would have had to sort through and hopefully pick the right one, and you can see how close they are. And it'd probably be pretty easy to accidentally select the wrong one. Add in a field to capture all of the sizes, but that sometimes is not available and would be a lot of extra work for you to try to figure out the sizes, or to go back and have the sites manually enter in the model number. So the decision was made that we need to have the sites manually enter in the model number. And I apologize, because I was hoping that we were going to make it simpler, but that option's not going to work for us to have them by harvest code. So you will need to enter in the full model number for the aorta devices. The other thing that I wanted to talk about, again, this is a free text field. I'm not sure why some vendors went ahead and made this a drop down, because we knew that we were going to be adding devices into that sheet. So this field here, the model number field, is set as a free text field in the data specifications and needs to remain that way, so you can type in those numbers. The other issue I wanted to point out regarding the aorta section is the composite grafts. So this is when you do an aortic valve or aortic valve composite graft is implanted, and it's a valve composite graft. You can select the device from the drop down here, the implant size and the UDI if you're able to pull that over. And then what happens is this field here, location for device 1, opens up because it's expecting you to enter in another device. Say if you did something further to the ascending or to the arch with that composite graft, it's expecting you to enter that in, but a lot of cases you don't do that. So there was an option here one time that it was X. You should have just been able to type in X, but for some reason that didn't make it over into the specs. So this is going to show up blank. You'll just leave this field blank. It might be this field in the implant method. Leave these blank, and it will show up as missing on your IQVIA missing variable report, and you can just ignore that. We'll fix it in the next version to make sure we make sure that X is in there for these fields, for that first field. And then I'm going to hand it over to Joe and Melanie for an update. So thanks.
Great, thank you very much. So let me go ahead and cover what's coming in an update this coming weekend on November 7th. So starting with a couple updates regarding the participant dashboard report, SCS 2994, and duplicates of that, SCS 2219 and STS 2068. The internal mammary artery used is displaying an incorrect case count. And so we are looking to correct that for you. And so that should be resolved this weekend. And then STS 3581, along with duplicate STS 3387. The graphs at the top of the dashboard were not matching correctly for the discharge mortality section. It's showing as blank, even though there is data present. And so we are looking to fix that as well. A couple updates regarding the missing variable report, STS 3419. We are looking at the logic for the Social Security number as it relates to the parent variable of Social Security number known. And we are looking into a display issue where that is showing up with a value over 100%. And so across the board, we are looking to correct issues with the Social Security number. STS 3603, the report is indicating that variables are missing, even though values are present on the form. Some examples of where this is occurring is for dialysis, warfarin, and direct thrombin inhibitors. And so that should be resolved after this weekend. And then STS 1864, we are updating the logic for initial extubation, for the initial extubation variable so that it shows up correctly when it should. There were some situations where it was appearing even though it was present on the case form. One additional note that is not listed here before we get into enhancements, we are aware that some users are still getting errors in regard to fields that were updated to allow for decimal values with version 4.20.2. Examples of that would be the VDV max or the VD grade A or the BNP. Those elements that should be allowing you to upload decimals still, despite our fix, are coming up as critical errors. And there is a workaround that you can apply from your side that will allow you to refresh the validations so that our fix goes through and allows those records in for you. So if I could share my screen briefly, I have a screenshot of how to, of what you need to click on to get that displayed. So give me just a sec. Okay, so when you're uploading, if you are still encountering the critical errors for VDV max, VD grade A, BNP, etc., any of those values that were updated to allow you to put decimal points in, when you select your file, you'll be on this screen that you see here in the screenshot. And normally you would click on upload file to submit it. Before you do that, there is a clear mappings button in the lower right corner of that box. Click that clear mappings button and confirm that, and that will allow you to refresh the validations. And then once you've done that, just click on upload file, submit as usual, and you should not get those critical errors related to those fields. So select your file. You'll have this screen here. Click clear mappings and confirm that, and then upload your file. And that should refresh the validations for you. All right, and that is my piece. So I will turn things over to Melanie, who's going to discuss some some validations that are, or excuse me, some enhancements that are coming in the coming release.
Hello, everyone. Thanks, Joe. Okay, so let's go to the next slide. Okay, so we are targeting for this weekend some enhancements that will also be included. One that we wanted to make sure that we noted to the user community is that there are additional validations that will be applied to the uploader. Specifically for the fields that are listed here, we'll be applying a critical error validation if the following fields are missing, and that's the surgeon NPI, hospital NPI, and the primary anesthesia NPI if the site has opted in for the anesthesia program. If those fields are identified as missing, those records will be dropped. And of course, the critical error message will be presented to the user. So those are required in order to be saved to the database. This is applicable for the 2.81, 2.9, and 4.20.2 versions. Okay, the next slide. So we do have quite a few updates related to the adult participant dashboard report, and that's the non-analyzed dashboard report. So this is not related to the risk-adjusted dashboard. Just wanted to highlight the updates that will be done in regards to the filtering, the newly added or updated variables related to 4.20.2, and we'll go through a couple of those examples so that you're aware. Okay, so the first thing that we did update is related to the procedure identification or PROC ID update for 4.20.2. So the procedure filtering that's available on the dashboard has been updated to include that logic. So I will show you specifically where that is. Next is there is applied logic on the dashboard that will identify patients that are identified as being in hospital alive. The specific variable that the dashboard will use is related to the discharge. You'll see the discharge MT patient acute hospital still. That variable, if it is set to yes, and this is applicable for the 4.20.2 version, this will not assign a PROC ID to those patient records that are identified as still being in the hospital or in hospital alive. Another update is related to updates to labels for existing variables on the dashboard. And another area of updates is related to the discharge mortality report section, where we've added new line items to capture the hospital discharge date missing percentage and the mortality date missing percentage. Okay, so I'll go through couple of these so that you're aware, and then we will have information posted to the library and also the notifications related to this release, because we do have quite a few items that we are covering, so we want to make sure that you have that information to be able to reference. Let's go to the next slide. Okay, so here's an example of where we are updating mapping for variables. So the most, the variable that changed between versions is race. So it went from the 2.9 version to the 4.20.2 version, where now it is a multi-select variable. And so that mapping in regards to those two different types of variables has been done. And you'll see here, when you are looking at the dashboard, you'll be able to see, of course, the same information, but the primary change that happened behind the scene is that when you cross the actual dates, your surgical dates, and you select a result. In this example here, we selected the result for the American Indian Alaskan. When you select that, you will have all of the different surgical date ranges appear, and then the respective data version. When you click on that actual case, you will see the respective form version available. So that has been updated. Next, let's go to the next slide, and we will be providing information again related to those variables that have been updated in regards to mapping, but that's just an example of one. Next, we have the PROC ID related to the 4.20.2 version. We updated the current filter, so you'll see on the right-hand side, on that parameter page, you will have the procedures option. So there's nothing that changed on the front end, and you will be able to, of course, select the options as you have before. The logic on the back end has been updated so that now it will, of course, consider the specific PROC ID logic changes related to 4.20.2. So you'll see in this example where we have the date range of 7/1/2020 through 12, I believe that's a 10/1/2020. It's really tiny. You'll see that that information is using the logic based on the 4.20.2. And that PROC ID chart is posted to, of course, the STS website. So the logic that is listed there on that document is the same logic that is used to drive this procedure filter. Okay, the next slide. Here we've updated the discharge mortality section, that report section, to now include the hospital discharge date, the missing percentage. So you're able to come here and quickly review hospital discharge date and the mortality date, the missing percentage for each one of those. So that is now, that will be available for you. And the next, I think I did not include a slide, but there again, the other one that I wanted to highlight is the fact that the for patients that are still flagged as still in hospital alive, they will not be associated with a PROC ID. So those will, there is a filter on that parameter page where there is a none option. So meaning that those cases that have not been assigned a PROC ID, if you needed to review those, you would use the none option on that parameter procedures page. Okay. So the next thing we wanted to cover is a new report for those sites that have surgeons that have elected to participate in the MIPS 2020 performance program and quality program. We are targeting to have this also included in the release this weekend. So we wanted to go through and just do a review of this report. So let's go to the next slide. Okay, so just a quick overview in regards to the report. The surgeons are able to, and the delegates are able to review the current MIPS 2020 measure report, which is an interactive dashboard. And with that, they're able to see their measure performance within a specific quarter, and they could expand that from Q1 all the way to Q4 when, of course, that information is available. We will go through a quick demo so that you're able to see how to access that report for those that have, again, elected to participate in that program. So we're able to just at least do that review. So the other thing that I wanted to highlight here is that once the reporting period ends, which is basically the end of this year, 12/31/2020, all of that information, once it's collected, there is a submission that is done to CMS. So that deadline, of course, is March 31st, 2021. And so all of those results would be submitted by the STS on the behalf of those consenting surgeons. And there are 9 identified quality measures that are sent to CMS. I did place the web link here so that you're able to quickly refer to this if you would like to see those specific measures. And the measure specifications are also available on the STS website. Okay, so let's go to the next slide.
Sorry to just chime in, Mel. This is Jeanette. I just want to add one item. So just because you've done the initial enrollment or the surgeon has done the initial enrollment does not mean the CMS submission will automatically happen. There is a secondary review process where the surgeons will have the opportunity to review their final results and approve the submission to CMS. So there is one more step in the process. It is not an automatic submission to CMS without ensuring that review has occurred.
And thanks for raising that. That's very important. And so that approval process is another step in this participating in this quality program. Couple other things that we wanted to highlight, because we did go through a UAT, or a user acceptance testing period, where we did have surgeons that participated and provided feedback. So some of the feedback that we received regarding the report was that it was easy to use, it looked great, and that it was reported, the report was intuitive, and they liked the fact that there was drill down capability to especially review those cases that were flagged as performance not met. So let's go ahead and go to the next slide. And I do have a screenshot available so that we're able to see. And then I will take us into a demo for it. So as you can see, this report will be available under the operational reports menu. Once the user selects that hyperlink to access, there will be a reports parameters page where they will be able to select the reporting year, which would be 2020, and then they would select their actual name on the drop down. So surgeons that are reviewing this report specifically will only have access to review their information. Delegates that are assigned are able to review all of the surgeons that are available within that participant site. So just wanted to also call that out. So let's go ahead and I'll do a quick screen share, and then we can take a look at the report. Okay, just give me one moment.
And just while Mel's pulling that up, delegates would be any of the data managers that have access to the system. So there's no separate access level that you would need in order to see that on behalf of your surgeons.
Yep, thanks for clarifying that, because I know we probably would get questions on that. And if you can just confirm that you can see my screen.
Yes, we can.
Thank you. Okay, so I've already navigated in, and I will just click on the MIPS performance measure report. And here is the parameters page that I was referring to earlier. And this is where we would select our reporting year. And in this instance, I actually am a data manager that has the ability to see all of the participating surgeons at this site. So what I will do is just select the surgeon name, select apply parameters, and at this point, generate the report. You'll see at the very top, you'll have identifiers that if you needed to print out this report, you're able to know that especially if you're participating with more than one site, you have your ID listed here, the reporting period, the TIN and NPI, and of course the surgeon name. And then you'll also notice underneath the report name where you have the quarter slider. And here you're able to use this interactive slider to be able to narrow down the search. By default, it is going to show all quarters. But if I wanted to view maybe a single quarter, I could go ahead and change that slider to be able to just maybe view quarter one. Okay, and then you can move that to then shift it to change to another quarter. So quarter 1 and 2. Okay, so you can see how that updates automatically for you. You'll see in the middle of the report, you'll have these bar graphs, and each one will represent a measure. One thing that I do want to point out is that the measure name has an asterisk next to it. If you see where there's a measure that has an asterisk, it does have a reference footnote that you see here, this report note. And basically for each of those measures, it indicates that they're designated as an inverse measure, which basically means that having a lower calculated performance rate equals better clinical care. So in these cases, the performance rate that's closer to 0% is actually better. So we just have that noted. And again, that's for each of the measures that have an asterisk. Underneath that, you'll see that you have a list of the actual measures with the breakdown of the time period, performance rate, the eligible population exception, and then whether or not the performance was met or not met. Okay, so for each one of these, you're able to review that information quickly, and it's interactive. So if I were to select on this line item for Q1, you'll see that the case list automatically updates with that information here. And so you're able to review the patient record, that specific measure, the performance status, and then also if you wanted to navigate to that case, you're able to select that hyperlink to be able to view that case information. All of this is also available for you to export. Same functionality that you're used to with the other reports that are available, where you would just right click and select the option to export or export to Excel. Okay, so same functionality that you're used to from the other reports. So I just wanted to, of course, make sure that everyone, at least for those who have consented and ready to review the information from MIPS, know that this report is on the way and you will have access to be able to review that. Okay, so I think at this point, I'm going to stop here with my sharing.
And while we
And
transition that back to Leanne, just one note. I know, I'm sure you all know this, but that is not real information that was just being shown. That was in a test environment. So those were not real patients. And those are not the real results for that doctor that was listed with an NPI. So that was all just test data. So nothing identifiable in there.
correct, that was Mike Test. If anyone saw the name of that facility, it was Mike Test. So that was our test facility for the MIPS. Okay, I think that may have been my last slide, Carol. Let's see. Yes, I think that was it. So now it's going on to the support plan.
Yep, so please submit your questions using your participant PID and your STS or the IQVIA ticket number if you have that. And we will get to your questions shortly here. Please contact me if you have any direct questions, ckrone@sts.org, or for database operational questions, stsdb@sts.org. And then I'm gonna go over to questions. I have seen a couple emails come through this week related to the STS risk calculator and it being updated. So ARMIS manages the STS risk calculator for STS. We have a contract with ARMIS to do that. The risk calculator you can find here under resources. It was updated for version 4.20. When you go in, you accept, and you'll see here new version 4.20 up at the top here after you accept it. If you're having issues with the calculator when you go in here, make sure you're entering in all your information. Make sure you're hitting calculate after you do that. Go under support and you can contact ARMIS directly here. An email will pop up and you'll see their contact information pull up. So please email them. I am CC'd on these emails. So if it's something that is happening on the STS side or ARMIS, it's not related to the online calculator, I'll respond to those as well. So please reach out to ARMIS if you're having issues with the calculator, and they'll be able to help you out. All right, and then the next question is, I can take this one. So does coding patient is still being in the acute care hospital in sequence 7005? You all may want to see these questions. Sorry about that. Does coding the patient is still being in the acute care hospital and setting sequence 7005 exclude the patient from being included in the harvest report data or only from the mortality measures? So these patients that are marked as still in hospital alive are excluded from analysis completely when they go over to DCRI. They are not excluded. I don't know, Melanie, did you build that in using the PROC ID for 4.2?
Sorry, Carol, say it again.
Sure, and Jeanette might know as well. The patients who are still in hospital alive with further discharge status, that was added into the PROC ID for version 4.2. Is that included on your side when you're filtering cases on PROC type in the unadjusted dashboard?
Yes, that's one of the points that was on the slide. So we were considering that variable. Yep, if you want to go back, it was updated to consider that variable. Keep
Great, thank
going.
you.
Right
So-
here, right there.
So it is included on the IQVIA side, and when those cases get sent over, so IQVIA is not displaying it, they're not applying the PROC ID to it. It's still sent over to in the file that goes to DCRI for analysis. DCRI also excludes these patients from analysis on their end prior to going in. I submitted 2020 Q3 DAT file. It got uploaded, however, the DQR is empty. Is this a known issue? Missing variable has a proper report.
This is Jeanette. I can take that one. So that means you didn't have any problems in your file. So kudos to you. So that's not actually a problem. That is okay. So we've gotten some feedback previously that there are too many messages in the DQR, and so there was an effort to streamline some of that. We've now gotten some feedback that you feel you'd like to see more messages in the DQR. So we are looking at adding some additional feedback points back in so that you should see some of that information that you are seeing in the MVR also in the DQR for the version 4.20 related submissions for those surgeries in Q3 and later. So we are, looking to strike that balance with you all and definitely appreciate the feedback, but a blank DQR does not indicate a problem. That is actually good news for you. And please do feel free to review the missing variable report where there are some more informations related to variables that are recommended for you to fill in.
That's wonderful. Thank you, Jeanette. Is there any update on the estimate date for report, including the hospital or STS benchmarks for all of the metrics, like our old DCRI reports? Thanks. So I can tell you that the surgeon leadership in IQVIA and STS have all been working together to finalize what those reports are going to look like and trying to optimize the graphs and things like that. It is in, do you want to provide an update, Melanie or Jeanette, on where it's at right now?
This is Jeanette. I can chime in on that. So we have a process, which I know you've all heard a bit about previously. So we work with STS and obviously review the existing example reports that you previously saw from DCRI, and also, where appropriate, review with the surgeon leadership team. So they get an opportunity to see the whole thing to make sure that sort of the mock-ups or the initial implementation looks good and that we've got everything lined up. And then it does get built, implemented, and then we go through a period of user acceptance test review or beta testing feedback with some members of the group. So at this point, we are in the building it phase of things, and we do look forward to getting some feedback from the user test community once that build phase is done. So without the buy-in of that review, we don't want to release it all to you. So we don't want to, say a target date prematurely, but it definitely is actively in development right now, and we are eager to make that available to you all as soon as it's been reviewed and approved.
Thank you, Jeanette. And just to clarify, building on that has started like a very long time ago. So it's not like it just started being built. It's been being built for a year, I think. So we're working on it and optimizing everything right now. Next question, clarification. I'm not sure I understand your question, Robin. It says clarification, the changes we discussed today begin 11/20. Is this the case we have? Is this the cases we have abstracted starting 11/20 or the 11/20 actual dated surgery cases? So I'm not sure. 11/20 is the deadline for Harvest 4, which may be extended. STS will let you know if that date is extended next week and what we can extend it out to if we're able to extend it. The changes that were talked about today regarding the aorta devices and the chronic lung disease, those are all related with cases OR dates of November 1, 2020. So please let me know if I didn't answer your question, Robin. I'm happy to provide clarification. Oopsie. Next question. If I emailed to add a user to be able to see the dashboard reporting in IQVIA in mid-October, when might they expect to get access? So Jane and her team are pretty quick about providing access. It's unusual that you weren't responded to fairly quickly, usually within a day, if not a little bit longer, but usually within less than 24 hours. If you haven't had a response yet, we can put the email address into the chat box for you to reach out. And I apologize, or you can just reach out to me and I'll be happy to pass it on to Jane as well. My email is here on the slide. There you go. Regarding the critical error associated with primary anesthesia name, do you have to say no to organization participates in anesthesia module so that this critical error does not occur? And I don't think so, because I don't think that's how that's working, is it? Because that question is only on the anesthesia section. IQVIA. Are you guys?
Melanie, are you there?
Sorry, I could not get off of mute. The VDV max, is
No,
that?
this is the
Is anesthesia name being required? Is that required?
Not for sites that, it's going to be required for sites that have opted into the anesthesia
And
program.
then there's that question of organization participates in anesthesia module.
Mm-hmm.
Are you using this question to verify, or what criteria are you using to verify?
We're using if they've opted into the anesthesia program.
Okay, not the question on the data collection form.
Not
correct?
the question on the, exactly, not that question.
Great. So that should answer your question, Cindy, because I know that there was a concern about that, since you can only get to that question if you have the anesthesia data on your form.
Correct.
Or, vendor software. So the reason why that's there, though, is to be apparent, because these were showing up as missing for everybody who was not participating.
Right.
Well, hopefully that's helpful. Next question, can you please show us in IQVIA how to get to the missing DC date and missing mortality data to help us ensure we do not go over the 2% threshold?
That would be visible within the missing variable report. And I'm not sure we have, we can really show that today, just given the time that's left, but we will put that on the list to show in the next meeting. And if you, Leisha, would like to reach out to the STS Tech Support at IQVIA.com mailing list, we can follow up with you to show you how to see that if you're not finding that within the missing variable report view.
And that's also been added to, so I had a screenshot in this slide deck where we've added those two fields also under the discharge mortality report section on the dashboard. And so you're able to view that information there. So there is a screenshot that's, if you want to go back, Carol, just I believe it's maybe 3 slides. If we go back, keep going. Oh, that's MIPS. Keep going. Right here. Hospital discharge, is that?
Yep, the
And
mortality.
the mortality date.
Mm-hmm. Operative mortality, I believe mortality date. So these are all listed here, and you can see your percent missing on the right.
So you have a couple places to be able to check.
Thank you. Next question, will we be able to see the MIPS report? And Judy, I think this is what your question is saying, so if I get it wrong, please provide clarification in the Q&A. Will we all be able to see the MIPS report even if we, well, I'm gonna think that you're saying even if we aren't participating in MIPS, and the answer to that would be no, only if you're participating in MIPS.
Well, they'll see the link. They will see the link. And Jeanette, I don't know if that's what you were going to say.
Yep, that's what I was going to say. I'll let you do it.
Yes, you will see the link. You will not, if there is no one participating in the program, you will not see an option with names appearing to be able to select. So if there is no surgeons participating in the program, the dropdown will not display any names. So you will not be able to get to the generated report if there's no one participating, but you'll see the link.
Thank you. Is this information being sent to the surgeons, or are we expected to relay this? So I'm assuming you're talking about the MIPS, and this information is only available to surgeons who have consented to MIPS, and we will be communicating out to those surgeons with this information. Jane Hahn, did you have anything to add to that? I'm cold calling on you if you're listening.
Thanks, Carol. Yes, we'll send out an email blast just to the consenting MIPS surgeons. We'll work on that internally. Is that what you said, Carol?
Yeah. Mm-hmm.
Okay. Yes, I agree. Thank you.
Thanks.
Sure.
How do we get a PDF of this new MIPS summary?
You would use the same export option where you're able to either right click on the report, or there is a file menu that you could also select file, and there's an option to export
To PDF.
to PDF. That's correct.
Thank you. Thanks, Joe. I had been, but I wondered how I would ever know if it was fixed if I always cleared the mapping. Is it an easy workaround so it isn't an issue? This is from Maria.
Oh yeah, I had responded to one of Maria's questions in text, and I think she was just replying to my response. But yeah, it's just a matter of clearing the mapping, and you should get around those errors, no problem.
Great.
And that's only one time that you're hitting that clear mapping button. It's not
Right.
every time you upload. So just wanted to also point that out.
All right. When is this functionality available?
So everything that we discussed during today's session is targeted for this weekend. So when you start back on Monday, you will see some updates within the system.
Okay, thank you. Deb says it would be nice to have a total for the year, not just quarterly totals. I think
So that interface, it's a slider bar. So if you look at the screen here,
right here.
it's showing the full year currently. But if you want to see just the quarter, you use the slider bar to zoom into it. So this view shows both results by quarter or results for the whole year.
Okay, thank you. Karen Hardy, you're asking about year-end 2019 reports, any updates? So the STS, that's the STS benchmark report, which is in the final stages of being built with IQVIA and the STS surgeon leaders and STS going back and forth. Hopefully soon. And that Susan puts in that the excessive blood products and the ICU hours greater than 100 and or longer in the DQR, those will be included in the benchmarked report that's due to come out. Somebody says that they've emailed IQVIA regarding star rating report because they did not receive one, and they were doing some investigation but have not heard anything yet. So you can feel free to, if you have your ticket number, if you could send that in and we could have IQVIA reach out to you for that one. On the MIPS dashboard, there are 3 different measures for tobacco screening and counseling. Are there detailed notes for each of these measures?
Yes, actually, that is on the same website that I have listed on the slide deck. That's on the sts.org. There is the measure specification for tobacco, which is measure 226. And in that document, there is specifics in regards to the 3 submission criteria.
Great.
So the information is available there.
Thank you. A couple questions about the CEs from AQO. So the process is that when you complete your request, it goes into a core Excel who manages our CEs, and they compile a list for us. Emily has to manually go through that list and compare it to the Cadmium platform to make sure that all of the content was watched in its entirety before she issues out or has Core Excel issue out the certificate, and they will be mailed to you. She's was waiting to hear from Cadmium for those lists. So hopefully they should be coming out by the end of November for those that have already claimed. But be sure, if you are going to claim credit, be sure to claim credit by December 31st. And I think I'm going to stop here because it's time, and I appreciate everybody. Thank you, Melanie, Jeanette, Joe, and the rest of the IQVIA team. Thank you, Melinda. And thank you, Sydney and Leanne, for all your help. And I hope everybody has a great rest of the day. We'll see you again. Let's see if we can find the timeline here. I'll post it up. I'll see you again on the 19th for our user group call at 2 p.m. Take care.
Thanks, everybody.